now.
All right. Hello, everybody, and thank you for joining us tonight for this session titled Closing the Gap, How Clinical Providers Can Provide Better Treatment and Care to Underrepresented Populations. I'm Ryan Davis. I'm a co-chair for the IDEA Committee here on the St. Augustine University. I'm actually the representative also out of the Austin campus. You may have seen some of the recent communications and town halls we've been doing, and this session is a direct response to trying to provide some information in response to those town halls. We are also very lucky to be joined by Dr. Aranha, an OT faculty out of Austin. She has been an occupational therapist for the past 26 years, and she has 22 years of clinical experience and rehabilitation and 6 years of teaching experience. She also has a Bachelor of Science in Occupational Therapy, a Master's of Science in Health, Exercise and Sport Science, and Biomechanics in the Biomechanics track. And she also has her Doctor of Philosophy in Human Development and Family Studies with a specialization in gerontology and human agency of the older adult. So she brings a lot of experience with her. She has also worked primarily in the US, but has international experience and has taken students on medical humanitarian trips to Guatemala, Nicaragua, and the US-Mexico border around the town of Laredo. And if any of you are in Texas, you're probably very familiar with Laredo. I know exactly where that is. In 2001, she lived in Bulawayo in Zimbabwe and worked with people and across the lifespan of several local organizations addressing the health needs of various populations. Her experience in Zimbabwe and in the global South have motivated her to advocate for individuals who are under-resourced and have disabilities. In 2016, during her tenure at the University of Texas Medical Branch, she started a student-led OT pro bono clinic for people without resources in Galveston. She is on the board of Occupational Therapy Benevolence Endowment, an organization that seeks to help occupational therapy professionals in times of crisis. As an occupational therapist and as an investigator, her experience and expertise in neural rehabilitation and finding ways to address neuroplasticity with people with acquired neurological lesions, community health, and global health. So those are some of the areas where she has focus. You can tell that she brings with her a lot of great experience, not only within the field, but also with working with lots of people from lots of different communities. So that's a little brief introduction. I'll let her take over the presentation from here, but I would encourage participants, if you have any comments or questions as we go through the presentation, feel free to put those in the chat. I'll be monitoring those, and we will have time for discussion at the end of the presentation as well.
So Ryan, I'm going to go ahead and start, right? Thank you, Ryan, for that introduction. I also want to thank the audience for being here. I know this is a busy time of the semester, and so being here is definitely means something to me, and I appreciate it. I want to thank the IDA committee and Ryan Davis for asking me to do this presentation, in particular, Dr. Pizzafero and Dr. Zadnik. You know, talking about health inequities and how clinical providers can provide better treatment and care to these, to the underrepresented populations is a serious topic. And so I feel humbled that I've been asked to talk about it. I do not see myself as an expert on this topic, but I've just been fortunate that through my life and through my experiences, I had opportunities show up where I could actually work in this area. And it has both been gratifying as well as it has been invigorating to know that I had a skill set where I could actually make a difference. For those of you who have attended the previous lectures, I know you've been introduced to several ideas that I'm going to be talking about today. And so my focus today is really going to be on reinforcing some of those thoughts on health inequities, but also to help us all think about how can we collectively address this issue. It's a big problem. It's a big problem all over the world, particularly here in the United States. And so today's conversation is going to be particularly focused on what's happening here in the United States and how we can help people here in the United States. But that's going to be the bulk of our focus, or my focus. Okay. And so the objectives is to understand the paradox of the right to health. And the reason I have phrased it that way is because we as a society for years have known health is important. We've had charters, we've had our professional code of ethics. We have the World Health Organization give us the international classification of function to help us take on a holistic approach. But yet what we see with regards to health disparities and health inequities says that we have a long ways to go and we're not meeting benchmarks. We're not doing as well as we need to. And so by the time you're done with this presentation, you should be able to understand and discuss health inequities and its impact on people's health and quality of life. And you should also be able to discuss the role healthcare providers can play in closing this gap with health inequities that cause that under-resourced populations experience. Okay. And so talking about the paradox to the right to health, right? Here's a quote from the book of Proverbs. They who have health have hope, and they who have hope have everything. We've known this for 2 millennia and more. If you look at all of the religious texts, all of them refer to health. In the book of Proverbs, it says, he who has health has hope, and he who has hope has everything. And of course, that was written a long time ago. And so I adapted it just because we need to embrace inclusivity. We know when they said he, it represented everybody. And so I adapted it, and hopefully I haven't offended anyone by doing it, but I did it for a good reason. Okay. Talking about what we as a society have done. After World War II, the Universal Declaration of Human Rights was passed. A group of legal experts, leaders around the world came together to talk about what we can do to enhance the dignity of life, to make sure that everyone's treated as equal. And they came up with 30 articles of human rights. The US was key to instituting or making sure that Article 25, the right to health, was included. FDR wrote out that article, did not live to present it to the UN, but his wife did. And it got included in the Bill of Human Rights, okay? This Bill of Human Rights was created by these legal experts so that if countries adopted it, it could be protected by the law. And several of the industrialized countries, as well as some lesser developed countries, have actually done that. Okay.
Dr. Arana, I have
Yes.
a participant just wondering, are you sharing a PowerPoint? Are you reading off a PowerPoint? Because we can't seem to see that if you are
Oh,
sharing that.
can't see it. I am so sorry.
No problem.
Yes, yes, yes. Let me see how I can. Give me a second. Why is it that I don't, oh, right there. Now, can you see it?
We can see the presenter view. We don't see the full presentation. We just see the presenter view.
Okay. Now you should see it, right?
Absolutely. Thank
Okay.
you so much. Sorry to interrupt.
I am so sorry about that. I do this all the time, and I didn't realize that I hadn't got it on. I hadn't shared my screen. Thank you for bringing it to my attention. And so to go back to the paradox of health, the right to health, each of our professions has a professional code of ethics. And that professional code of ethics helps us to adhere to a system of values that further ethical behavior and also strive for fairness in delivering services and in allocating services. The main ones that kind of come to my mind, or which I decided to put in here, was that of beneficence. where we defend and protect rights of all clients, where we engage in acts of mercy, kindness, and charity, and taking action. We have the code of ethics of non-maleficence, that's abstaining from causing harm. We have justice, yeah, where we work to uphold a society which holds all individuals as equal to achieve occupational engagement as an essential component of their life. Being an OT, I took this from the OT Code of Ethics, but I'm sure every discipline, whether it's nursing or PT, would have some form of justice addressed in their Code of Ethics. And then finally, another one that I thought that was very telling and very important for us, and especially this topic, is treating people with fairness, respect, and integrity. Um, so besides the Professional Code of Ethics, the World Health Organization decided that the medical model of care was not doing what it needed to do as far as healthcare, especially with the epidemiological transition, where previously it was all infectious diseases and we needed a medical model of care. We were now seeing chronic conditions. These chronic conditions were because there were other issues that were really impacting health. And they, with their pool of experts, came up with the International Classification of Functioning, Disability, and Health, which included environmental factors, personal factors. They said we needed to take this into consideration. We needed to look at not just body functions and structures and activities, but we needed to look at participation in the community. And so this model not only shed light on, or not to say shed light, but it was a model where all healthcare providers could use, and we would have a common language to speak from, as well as it was a holistic model of care. And so all along, every one of these documents, every one of these charters, this model of care was to make sure we were providing the right care, as well as we were taking into consideration environmental factors and personal factors that were impacting health. But despite all of these strategies that we have adopted, and despite all of these documents that we have to make sure we're on the right track, epidemiologists are finding that there are gross health disparities. Okay, the US life expectancy is low in comparison to other industrialized countries. Infant mortality rate is high compared to other industrialized countries. I think we rank somewhere in the, I think we rank about the 30th amongst all industrialized countries. And so that's behind Slovenia and Belarus and Cyprus, which are the Eastern European countries that joined, well, they're just the Eastern European countries. Our statistics are also telling us that our racial and ethnic groups, our minorities, have poorer health outcomes. These poorer health outcomes are preventable and treatable. These racial and ethnic minorities are also having problems with access to care and quality of care. And I think one of the most telling things is that the social environment is found to be the major contributor. Places where people live, work, play, and learn affect the health outcomes. And something else to this point is that effects last across life and across generations. A few weeks ago on PBS, they were talking about the state of Alabama and the infant mortality rate there. And to this day, they're finding that those regions of Alabama that had the slave plantations have a higher infant mortality rate. And so that speaks to the point that these effects last across generations, okay? And so gross health disparities just tells us there's a difference between there's a difference in population health, but the underlying cause is the health inequities. And so to unpack health inequities, I thought was important for us to figure out, okay, what are health inequities and what is the underlying problem? And according to research, the underlying problem is poverty, structural racism, and structural discrimination. And even though when we talk about health inequities, the two groups of people that kind of get flagged are by race and ethnic groups. If we look at the underlying problem of poverty, structural racism, and discrimination, gender is included, sexual orientation, gender expression are included, age is included. The more feeble the person is, the more they cannot speak up for themselves, they tend to have more health issues and less access to care. Persons with disability, socioeconomic status is a huge issue, and geographic location. When we talk about geographic location, it's rural, rural populations versus urban populations. Rural populations tend to experience more health inequities. Um, the unequal power and resources these groups experience cause issues with health. And so really the problem is outside of traditional healthcare. However, it impacts health. And so because of that, we are involved. And I decided to put this next slide together just to show how, depending on where you're born, the power your family has, the wealth your family has, it can play a huge role in your well-being, your health, your life expectancy, and that morbidity and mortality. And so I got this out of the National Health Services from Scotland, because they have a very good public health system. And the only reason I got it was because of its simplicity. Looking at all of the schematics across the world, and particularly here in the US, all of them speak about the same factors and how it impacts health. But this schematic tells us that the fundamental causes for these health inequities are power, wealth, and income. Depending on the power, depending on the wealth, depending on the income, your job opportunities, your education, and the quality of housing that you live in are affected. This then affects your individual experiences. Those with better job opportunities have a better income. They have better housing. They're not discriminated against, and they have access to health services. And that then gives a better quality of life, better health, better well-being, and they live longer. In fact, in the city of Glasgow, they found that just depending on where people lived, there was a 15-year lifespan difference between the poorer neighborhoods and the wealthier neighborhoods. And that's true even in here in the US, okay? Um, and now we know there are health inequities, and we've known it for a while, but on comes COVID-19. And COVID-19 is highlighting what we've already known. And Nancy Krieger, who is a professor of public health in Harvard H.G. School of Public Health, this is what she had to say to the New Yorker. She said, COVID is pulling a thread that is showing how many things are actually connected. And what she means by that is the inequities in health status and the inequity in healthcare. And these inequities in health status and healthcare are affecting the people that belong to who are structurally discriminated, like people from racial and ethnic minority groups. And I got this graphic out of the Brookings Institute website, which shows how, and it compares, give me a second here, it compares 4 different states, and it looks at the population of Blacks or African Americans in that community versus the number of positive cases for that community. And it shows that the African Americans are disproportionately higher with COVID positive cases, as well as with those that are dying from COVID. And this is not just true of the African American community, but it's all of those people that are living in places where they're all those that are experiencing unfair opportunities for economic, physical, and emotional health. And so really that underlying cause here then is structural discrimination. People who live in poor neighborhoods, who have historically had this legacy of redlining, where air pollution is high. Surprisingly, well, not surprisingly, but recent studies are finding that poorer neighborhoods with a higher air pollution rate are also having a higher rate of COVID. These particular people that come from these neighborhoods also are dependent on public transportation. They cannot afford private transportation, nor can they afford to have their own cars. And when you're depending on public transportation with a pandemic like this, you're in close proximity to people. These are populations that make up the essential workforce. Unlike a lot of us, they're not able to work from home. They have to show up at work. They have poor healthcare access and they lack adequate health insurance. Um, they have poor access to PPE. We're finding that people who work in, some months ago, we had heard about people who work for Amazon who did not have the right PPE equipment. People in meat packaging industries have a high rate of COVID. These are also populations that lack a living wage. Because of a lack of a living wage, there are many more people living in one household. And again, something else that I think is very telling or puts them at a greater risk is they have a lot of pre-existing health conditions because of years of structural discrimination. Again, I say the underlying cause is structural discrimination, but I think what I really want to impart with this particular slide is, because we healthcare providers very often, and I'm at fault for this, is when I look at someone who may be obese or someone who may have um, healthcare problems, chronic conditions, the first thought that comes to me, my mind is they've not been taking care of themselves. But research is telling us that's not the case. It's inadequate healthcare resources that these people are experiencing. So the next few slides that I'm going to show you are just slides to kind of bring home the fact that structural discrimination is affecting people. And in my own personal experience, when I moved to Lubbock, Texas, I'm right now living in Austin, but in 2017, when I went to work at Texas Tech in Lubbock, Texas, one of the things that I wanted to do was start a pro bono clinic there just because of my past experience. And I thought it'd be a good way for students to actually experience working in pro bono clinics. And so I, with a group of students, and I decided to do a needs assessment of the town to kind of figure out who are we going to partner with, where would be a good location for a healthcare clinic. And what we found was that all of these red dots were rehabilitation clinics, and they were all on the wealthier side of town. If you look to the east side of town, this was the poorer side of town, and there was not a single healthcare clinic. Granted, or I guess we've got to acknowledge the situation there. Lubbock was a segregated town till 1970. It only got desegregated in 1970, and you still see the difference between the two neighborhoods. But I guess this one little map shows you how people from the east side of town, if they needed services, had a long ways to go in order to get the kind of services they need. And also rehabilitation services, we are in a system, a healthcare system that is reactive rather than proactive. But we definitely can be proactive, and we can definitely help people in community health. And so definitely that was lacking in this neighborhood. Here is a link that I have. Here is a short clip that I have to what immigrants might face when they experience structural discrimination. And it's just a minute long, so let me just play it for you. Okay. So again here, this tells us the challenges structural discrimination poses. Immigrants that come into this country tend to go live in low income neighborhoods because of a lack of finances or whatever it is that gets them there. But when they first move into the country, they do have good health, but it's the neighborhoods that they live in them that account for that lack of or that decline in health. Um, Give me a second here. That was not. My next slide talks about structural discrimination, but again here, see what it does to the loss of culture and health. And this has to do with an American Indian, with the American Indians. And so this tells you how a policy decision to benefit the dominant culture robbed a native culture, their quality life, and doomed them to a life of chronic disorders. So, oh, sorry. So, so what does this mean for people who are under-resourced, right? For all of these different communities where because of their situation who live in poorer neighborhoods, who are experiencing health inequalities, what does this mean for them? And I think it's important for us to realize this so that we know where exactly to help them out and how to help them out. And people who are under-resourced generally have limited access to healthcare, right? You saw in that little map that I showed you of Lubbock how there was not a single rehabilitation clinic. There was not even a hospital. You know, Lubbock, a city, is a major healthcare hub. and has 4 or 5 major hospitals for 200,000, I think, 250,000 people in that city. But there's not a major hospital in that poorer neighborhood. And so these people definitely have limited access to healthcare. They are at risk for chronic disorders. These are people who have cultural linguistic barriers that limit their quality of care, because even though they may speak English, and even though they've lived in this country for a couple of generations, just the way they do things may be different, and that could then cause cultural linguistic barriers. There's provider bias that can limit quality of care. um, Depending on the type of insurance they have, the more private insurance, the better care they receive, right? And again, for the people that are under-resourced, they may seek comfort. They may want people, they may need providers who understand them and would communicate and interact with them the way they want to be treated, and the way they want to interact with. But generally, these are minorities that are underrepresented in healthcare. And so that chasm between the under-resourced and those that are resourced and our healthcare system is vast. And so we healthcare providers need to know how to close the gap. And so in the next few slides, we will talk about just doing that. How can we collectively close this gap, and what do we have to do? Um, One of the first things I think is important is to figure out, who do we collaborate with? Um, it requires a lot of money to just go out on a limb and start a clinic. And so additionally, there's not really much funding for community health for allied health professionals. And so who do we collaborate with? And so I think it's important for us to think of the philosophy in healthcare. Depending on the philosophy of healthcare, various institutions have been provide health services. And so, and their philosophy of healthcare is going to determine how they run their businesses. And so for us allied health professionals, knowing what that philosophy of healthcare for a particular organization is will determine whether they would make good partners and stakeholders in our cause to close this gap. And so when we're looking at the different philosophies of healthcare, there's one philosophy which says people should be able to access care when it's needed. Now, we're not sure if this access to care when it's needed includes screening or includes preventative care. And so that's something we need to make sure that it covers, because very often our people who are under-resourced may need things like screening and preventative care to prevent chronic conditions. Healthcare is a right, right? Our US Constitution believes in a right to life, but does that also equate to a right to health? I think the closest that we come to where healthcare is a right is Medicare Part A services, which covers your problem no matter what the problem is, and covers 100% of the healthcare bill. Healthcare is a business. We know these are for-profit healthcare organizations, and even though they may give a portion of what they do towards addressing health inequities, they may not fully embrace what you may want to do. Healthcare is a privilege. These are institutions who may have boutique healthcares, or may have, or may have genetic testing and things like that. Again, these may not be the right partners to collaborate with. We have healthcare as charity. These are people that indulge in this kind of or institution, or when I'm using the word indulge, I may not be using it right, but who would advocate for healthcare, who belong to this philosophy, are people who belong to religious groups, people who philanthropists, right? People who may be indulgent in their lives but may feel like they need to contribute in some way to charity. So these are people that definitely would want to see healthcare provided to those that are under-resourced. And so these would be good people to look for in order for us to collaborate with. The other philosophies of healthcare as a science, like John Hopkins and Mayo and all of those clinics, but and they definitely would contribute. But again, this is more the people that they kind of would accept within their healthcare service of delivery would be those who are willing to engage in research or would willing to engage in clinical trials. And finally, healthcare is a self-directed activity. Um, with healthcare as a self-directed activity, it's only those who seek healthcare receive it. What about those who do not want to be vaccinated and all that, right? And so I think it's important for us to know that there are these different philosophies. I don't, although I did say healthcare as charity would be the best philosophy for addressing this issue. But again, I think it's important for us as healthcare providers to know there are these different philosophies and see which would be the best match to best match for us to collaborate with and partner with. And when I started off, I did mention that this has to be collective action. And so while we're talking about what healthcare providers need to do, I think there is also a role for educational institutions. I think it's really important for educational institutions to introduce health inequities in curriculums, to provide cross-cultural education, to provide experiences to volunteering with under-resourced communities. Starting pro bono clinics, research has shown, introduce students to working with under-resourced communities. And then when they graduate, these people know how to navigate the system to then set up clinics and work in these communities. And research has shown that's happening. And so I think it's very important for us to look for opportunities where we could partner with so that we can provide students these opportunities. And something else that we found, and which I mentioned earlier, is minority groups are underrepresented in healthcare. So increasing student enrollment of underrepresented groups in healthcare is very important. Um, Providing culturally sensitive care. When there is that gap or there is that hierarchy in a healthcare system, very often we're not providing the right kind of care that people are seeking. And so it's important for us when there is a communication barrier to acknowledge it and address it. We need to learn to embrace diversity. On purpose, I use the word culturally sensitive rather than culturally competent. Culturally competent comes from a medically managed healthcare system where we are told that there are differences and we need to develop a skill set to provide culturally competent care. If we are culturally sensitive, we're going to embrace the diversity. We're going to embrace the cultural background our clients come from, and then we can collaboratively work with them in order to address their healthcare issues. And this may be a more sustainable way to go because they may have more confidence in you and may actually adhere to what you might be telling them. Okay. And my next point, promote racial and ethnic diversity in the workforce. We've spoken about it. And finally, I wanted to bring attention to the site that's which is Think Cultural Health. It is set up by the Minority Health Department, and it has CEUs for cultural competency. So those healthcare providers or even faculty who want their students to improve their cultural competency, this is a great place to have to take some, take some CEUs and get some training. And my next slide, I have a little clip that really talks about think cultural health and what they think about cultural competency and cultural sensitivity.
Dr. Arona, before you start this clip, some in the on the other clips we haven't.
Sorry,
It's okay. We
let me
haven't
stop
been.
it. Okay. Oh,
Um,
okay.
there we go. So just on the previous clips, some we weren't able to hear
Uh-huh.
those. So we were able to read the captions. I didn't know if there was a way that you would be able to alter the sound so that way we'd be able to hear the videos as well as read the captions.
Oh, y'all couldn't hear the videos?
No, ma'am.
Sorry.
That's okay.
Um, Everything that I know what to do, I forgot what to do. So I should have done share computer sound. Let me
It's
do that. What's it?
that's okay.
Yeah. Oh, so the other two videos too, y'all did not hear the sound?
Correct. But we all read the captions. We all were able
Oh,
to follow
okay,
along
okay,
because of the
all right,
captions.
okay. Now this video is important. You'll hear the sound. So let me get that going.
And it might also be because the sound is playing through your headset, so we can't hear it. That might contribute.
Okay, so let's try. And if you feel like it's you're not hearing it, let me know, and I'll take off my headset. Okay.
Also, Karen, when you
Yeah.
reach share,
Hi, I'm
there
a
is
physician and I'm
actually a place where you can click to share the sound on the bottom.
That's what I did.
That might also help. Yeah, perfect.
Yeah, when I started off, I forgot to do that, and yeah, my apologies. Yeah, I've done that, so I think you should hear this. So let's see if you hear it. If you cannot, I'll take off my headset.
to tell you that health disparities matter. African American men die an average
Can you all hear it?
Yes.
Okay, great.
10 years earlier than white men in the city of Chicago, and that disparity's persisted for 20 years. It's time to do something about it.
Once a Russian-speaking woman came into our office with a letter in Russian, and she asked us to translate it into English and send it to the local hospital. The letter said, "When the hospital asked my older child to translate for the birth of my new baby, I felt like an animal, zvier. But later, when the hospital offered me an interpreter for the birth of my next baby, I felt like a real person, nastoящий человек."
You know, oftentimes providers, I walk into a training room and they think that what I'm about to tell them is irrelevant and completely peripheral to the real work. And I tell them what I'm about to talk to them about, that cultural competence is as important to the outcomes of their patients, is as important to the mortality and the morbidity rates as anything that they're going to do in terms of pharmacology or surgical procedures. In order for a patient to be healed, several things have to happen. They have to come to the medical facility. They have to give a complete and accurate medical history. The provider has to order the correct diagnostic tests, and then the provider has to make the correct diagnosis and develop the best treatment plan for the patient. And the treatment plan has to be one that the patient understands and is motivated to follow. All of those steps require a good relationship between the provider and the patient. It requires trust, and that is completely dependent on the cultural competence of the provider.
What we've seen, for example, within the Latino population in an area of New York State is their lack of awareness to language access resources. So not being able to communicate with their providers, it causes a barrier which contributes to health disparities such as not seeking preventive care, not finding somebody who would be able to deal with primary issues, but unfortunately having these medical issues escalate to a point that they become one of the statistics that are recorded in health disparities issues.
America's a country that's getting more diverse every day, and that's a challenge for healthcare organizations. Doctors, nurses, they want to treat people the best way that they possibly can, but they don't always know how to do that. And the great thing about the class standards is that they provide a path, a journey, a roadmap for getting to better quality care and to really deliver care that's very patient-centered. And when hospitals and doctors can do patient-centered care, that means that not only do diverse populations get to be healthier, but everybody gets to be healthier.
I want to tell you a story of a community health center in North Carolina where they were trying to incorporate health literacy practices with their population. And they decided that they were going to ask their patients to explain to them how they were going to take their medicines. And they were astonished. They found that 9 out of 10 times they uncovered mistakes that the patients would have otherwise made had they not had a chance to confirm their understanding and correct it. So this is an incredibly important issue to address for safety as well as communication.
Cultural competence and language access matter. We've heard it all. The abusive husbands asked to interpret for their battered spouses and girlfriends. A young mother of a dying baby asked to tell her husband to interpret for her husband the baby's dying, and the husband who yells back, "You're lying, I don't believe you." A Haitian woman pregnant, treated at a hospital and released for dizzy spells, who then weeks later learns she had an abortion there without her knowledge or consent. And the kids asked to interpret everywhere. Tell your dad he has HIV. Tell your mom she has advanced ovarian cancer. Tell your auntie her fetus is dead in the womb. We've had cases, 2 cases of children as young as 3 being asked to interpret for their own pediatric encounters. And an 11-year-old boy who was asked to interpret for his own mother and told her, "Please don't cry, Mama. They tell me I have cancer." If it isn't culturally and linguistically appropriate, it isn't healthcare.
Do you think language doesn't matter? Nelson Mandela says, if you talk to a man in a language he understands, that goes to his head. If you talk to him in his language, that goes to his heart. Ensuring those who come to us for help understand the care they are receiving is essential for their satisfaction and safety.
I once interpreted for this elderly lady who had been coming to her primary care physician with her grandson to be used as an interpreter. It turned out that the information the doctor was obtaining through me was so different from what he had been getting through her grandson that he felt he really didn't know this patient, although he had been seeing her for the past 20 years. So he decided to cancel the rest of his afternoon appointments to really get to know her patient through an interpreter.
A Chinese interpreter once told me this: when a non-English speaking patient comes to the hospital, everything is strange. The sights are strange, the sounds are strange, the smells are strange. The only familiar thing in this alien environment is the voice of the interpreter. And it is the voice of the interpreter that allows this patient to connect with the doctor and to actually receive the health care that he deserves.
We all need
Sorry, it's just a little bit.
to work together to advance health equity at every point of contact.
Okay, and so I thought this little clip spoke volumes, and that's why I added it, even though it was a little long. But cultural competence and cultural sensitivity is such an important skill that's needed in helping people feel accepted, helping people adhere to recommendations that you're making, as well as treating people with dignity.
And can we go back to the full slides as well, please?
The full slides?
Yeah, we're seeing
okay.
the presenter view.
Oh, okay. Let's see, give me a second here. Are you seeing this? Are you seeing the
We
screen?
are, thank you so much.
Okay, great. Okay, and so I think this is my last slide, but engaging in advocacy, I think, is very, very important. Allied health professionals need more visibility in community health and primary care. With the advent of the Affordable Care Act, we started seeing more access to community health. And all the gains that we saw right up to 2018, now with the Affordable Care Act being attacked and dismantled, according to reports and according to literature, there's now a decline in health inequities. I'm sorry, what I'm trying to say is we're now seeing more problems with health inequities. Okay. We need a strong public health system. I think that's something that the US sort of lacks. There are other countries which have good public health systems and are addressing these issues in a better fashion. We need to engage in research. And when we talk about research, especially with these populations, it needs to be community-based participatory research, where we as researchers actually work with these communities as stakeholders and as researchers, where together, where we empower them and they can own the findings, as well as they can advocate for change within their community. And finally, engage in healthcare policy debates. I know here in the US, engaging in politics or talking politics is not, is frowned upon. But I think that's where change happens. And that's why we need to be vocal and we need to be able to engage in these debates so we can make a difference. And now I don't know how to go to my next slide. Give me a second here, sorry. Why did that happen? Okay. Can you see my slide?
No, not yet.
Not yet. Oh gosh. Why am I having trouble?
It's okay. We all understand.
Give me a second here. So I need to go back to Ring Central. Let me get, and it's just one slide. And
well, while you're working on that, we did have somebody, Hannah, in the chat just talk about how she couldn't agree more with the video about the interpreter. She said that she's seen firsthand in fieldwork how connected clients are with their interpreters and how it can make all the difference in the world. And Hannah actually spoke a little bit about how she's bilingual, she speaks Spanish, but wants to become a certified medical interpreter just because she knows that it's, you know, so important and so critical in the healthcare environment.
right. And I've got some resources at the end which will help, especially people like Hannah and other students kind of watch, because sometimes it's just that awareness that we need to be a little more perceptive to people's needs. You know, I've worked in countries where definitely language is a barrier, like countries like Botswana and all of that. But sometimes when people know that you've got your heart and your soul and your mind right there and you care for them and you embrace them, sometimes that takes care of the language barriers, okay? And so, yeah, towards the end, I've got these links that I will share with you also, that you'll have some resources to leave this place, leave this presentation. But now I'm having trouble getting to that last slide, but give me a second. Okay. And so before I go to this slide, let me talk, I mean, and these were slides that were shown, that were presented in previous talks. And this was something that Martin Luther King said in 1966 when he took part of the Poor People's March at Lafayette Park. And he was talking to the medical community, Committee for Human Rights. And he said, of all the forms of inequality, justice in healthcare is the most shocking and inhumane. Now, this was in 1966. Fast forward, and we still have not resolved the problem. In fact, in some cases, it's even gotten worse, right? And something else that another great icon who who definitely introduced the Affordable Care Act, Barack Obama said, ensuring access to quality, affordable healthcare helps create the opportunity for all citizens to achieve the American dream. Despite advances in medicine and technology, disparities remain in our healthcare system for too many Americans, including racial and ethnic minorities. And finally, give me a second. I think I need to go back to this one. And so my parting thoughts are, we have to do this collectively. And it's not just the healthcare provider, but like I said, it is finding people in the community who want to make a difference, partnering with having educational institutions, pick up some of the tab and try to ensure that students are educated and introduced to cultural differences, and having that cross-cultural curriculum, I think are all very, very important. And so, John Lewis passed away a few weeks ago, and I thought he was a great icon for civil rights, and this is a civil rights issue. And I thought I'd end my talk with his words, which said, "So I say to you, walk with the wind, brothers and sisters, and let the spirit of peace and the power of everlasting love be your guide." And this is a problem that cannot be resolved in a day, but requires thought and requires collective engagement in order to be resolved. And I need to share my PowerPoint with you all so that you'll have access to the resources that I have on my last slide. And I'll do that, I'll give it to Ryan as well as Dr. Pozzafero, and get the PowerPoint across to all of you.
Perfect. Thank you so much for your wonderful presentation today. Do you have a little bit of time to maybe field a couple of questions or participate in the conversation? All right.
I do. And I do want to apologize the problems I had with my PowerPoint. I guess, I don't feel like an expert on this topic, and I may have been too nervous to get to do all the right things.
No, I think you did a great job, and I don't think it detracted at all from your message or your presentation abilities. So, I mean, we don't have a huge group here. So I would say if anybody has any comments, questions, anything that they would like to say, please feel free to unmute yourself and, start a conversation.
Karen, this is Mary from St. Augustine. I kind of have a question about, sounds like you've done some work in other countries. And what did you have to do to, I guess, a lot of people want to go and do mission work, and I'm not opposed to mission work at all, but sometimes we go in there and we're like, oh, we're going to help these people. So can you talk about any practices you engaged in to maintain your humility in these settings, or even in Lubbock, Texas, in a, area which wasn't part of your own culture?
Thank you, Mary, for that question. So my first experience was when I went to Zimbabwe in 2000, and I had not planned to work. My husband got a Fulbright fellowship, and I thought I was going to have a holiday for a year. But the minute I landed in the town, I found that people were calling me because they realized there was an occupational therapist who was visiting, and there was not an occupational therapist. The last occupational therapist had left a few years ago. And so when I realized there was a need, and the country did not really have any rules or laws against licensing, the American license is accepted almost everywhere, maybe not in France, but most countries it's accepted. And so I got down to working. I worked in a school. They paid me, people there, I had decided that I was not going to charge anybody. I saw people at home. And so, so I had a wide range of people that came over to my place for treatment. And so there were the very wealthy and there were the very poor. And since I decided not to charge anybody, it was amazing to realize that people were grateful for what was given to them and what was done. And one man offered me his car for the year that I was there. Poorer people would get me milk, chickens, and eggs. It was almost like a barter system. And so I really got to understand the culture, and I really got to integrate. And so that whole year was just a wonderful experience. I worked in a school where we had kids with disabilities who had their own garden. At the end of the week, we would, go down to a local market and sell the vegetables. And so it was a good experience for me, not only to immerse myself in that culture, but also then to also give back to that culture. And so that was my experience with in Zimbabwe, where I really hadn't decided to go and do any work, but it just sort of happened. In Nicaragua, as well as in Guatemala, when I went, some of the things that I felt like I went with missionary groups. And so I went with, as a educational program that partnered with missionary groups. And some of the things that struck me and came across as not right was it looked like we were engaging our students in global health tourism. We took them for a week and we went, this is poverty, this is what it is, and we left. There was nothing done for sustainability. Again, the programs that we partnered with had these very rigid rules for those clients that came and accessed their facility. For one thing, they had to embrace the religious, the evangelical views. They had to dress in a certain way, and that dress code did not apply to Americans or other people that came to that setting. All of them had to wear dresses. And so I felt like I wanted to go there and provide healthcare irrespective of the religious affiliations they had. And so that was something that that was something that I felt like was a problem when I partnered with these missionary groups. Something else that happened when I went to Nicaragua was, I felt like we were lecturing to them about drinking clean water, because the huge issue there is a lack of clean water. And so we had a whole session, and we were about 30 of us, and the message was, you got to drink clean water. And I came away thinking, instead of preaching to them, we need to show them how to get clean water and how to access clean water, because everyone knows that you need to drink clean water. But how do you do it? That's what is important. Rather than lecture to them, it's get in there, immerse yourself in the culture, understand their problems, and work with them. Something else that my students, I thought, it really created a good impression, and they really kind of learned from this experience, was they wanted to take assessments for handwriting skills and all of that. And we found that, and they found that the girls did significantly better than the boys. But culturally, girls go to school, whereas the boys work on the farms. And so boys are not interested in handwriting. And so really our assessments were not of use in that setting. And so I know I've given you several different scenarios, but I think it's very important to actually go there and immerse yourself in the culture, understand them, work with them one-on-one, where they see why you're there to help them out, and they are very appreciative, but to understand them and address their needs based on what their needs actually are.
Thank you so much. And I know that we're a little bit over time, but if anybody wants to stick around, maybe we'll take one more question or comment if there's anybody out there who has one. All right, going once.
Is that it?
I think that might be it.
I have a question.
Okay, Hannah.
Sorry. How would you recommend going about finding a job as an OT abroad, and where would you start?
So there are jobs. The only problem with the jobs are they pay a lot less than the United States does. Mm-hmm. And so if you're looking to pay your loans off, then that becomes a problem. Now, having said that, I think, again, depends where you want to work. Do you want to work in developed countries like UK and New Zealand? There are lots of companies that recruit therapists to those countries. The underdeveloped countries, I think the best way to go about is to partner with either with missionaries or even just travel down there and meet some healthcare professionals and kind of create contacts. But from the United States, sometimes it's very difficult to make those contacts.
Mm-hmm.
I mean, just like my example that I gave you when I went to Bulawayo, where I felt like I didn't realize there was such a need, and I just went there and I had a whole year where I just saw clients the whole year round.
Okay.
Okay, if that helps, yeah. Yeah, I think it's important to get out of the United States, depending on where you want to go and where you want to work. Sometimes it's hard to make those contacts and those connections from this far. But there are many places in the world where there are no OTs.
Yeah.
In Guatemala, there was one OT, I think, in the whole country when we were there.
There's definitely a need.
Yes, definitely.
Okay, thank you. So I will say that, Dr. Pusafera is recording this, and I know that Dr. Arana is going to provide her PowerPoint, which we can distribute as well. But, as with any other faculty members, or please feel free, I think she would welcome an email if anybody wanted to ask her any questions. And also myself and the rest of the IDEA committee welcome any emails or questions or suggestions that you may have as well. And just a reminder, we do have one more session, our fourth session in this series of 4 presentations next Tuesday at the same time. So if you enjoyed this one or any of the other ones, we would definitely invite you back for our last one. And again, we appreciate all of you being here and attending.
Thank you.
Thank you, everybody.
So Ryan,